So welcome everyone to our CTSA and Columbia Implementation Science Seminar Series. We are really lucky to have Dr. JD Smith today, who's going to be talking about innovations and rollout designs. And I don't even know if I can say it, rollout implementation optimization design in particular. So I'm excited to hear about this. JD is an associate professor of population health sciences at the Spencer Fox Eccles School of Medicine at the University of Utah. And there he directs the Dissemination and Implementation Science core of the Utah CTSA. His work focuses primarily on the development and application of innovative implementation research methods. So he's done a lot of work on study designs. And he's done a lot of work on a range of areas from adult and pediatric primary care to cardiovascular and mental health and health equity. And he's also MPI of an NHLBI funded Chicago Implementation Research Center, the NIMH funded mental health, and earlier the Alacrity Research Center. So he has directed a lot of centers and done really great work. So excited to have him here and share his expertise today. So I will hand it over. JD, thanks.
Thanks, Rachel. Thanks for having me. As I mentioned for folks who were on a little bit ago, but reminder for anyone who just joined, I have no problem being interrupted. It's easiest to use the hand raise function for me to be able to see, but definitely drop questions in the chat as well, and we'll get to them either simultaneously or at the end. So yeah, going to talk a little bit about some new innovations and rollout designs, generally speaking, and then spend about half the time this morning, or I guess this afternoon for y'all, on the ROIO design, which is a relatively new study design for optimization. So just some standard disclosures. I don't have anything to disclose. I don't make any money off any of this stuff, obviously. Acknowledgements. I do want to thank Hendrix Brown, who taught me a ton about rollout designs and also is co-developer of the ROIO. Funding, I have funding from NIH for now, the CDC, as well as the AHRQ, and several foundations fund my work as well. No pharma or anything like that, though. So I just want to say, too, that I do have a lot of experience with rollout designs. These are studies that have used some form of a rollout or stepped wedge that I've been the lead implementation scientist for. Yeah, you'll get to see a couple of examples from these as we go through, but not all of them, unfortunately. Don't quite have time to give every example. So the goals today, help people understand the defining characteristics of rollout trials for implementation research, give you all a sense of the types of rollout designs beyond the stepped wedge. We all know the stepped wedge. Some of us love it, some of us hate it, but everyone knows what it is. So that's kind of a good starting point for us. And then we'll talk about alternative designs for implementation that can help you answer additional questions, but also just give much more flexibility in the actual execution or design of these designs. And then I'll do a little brief introduction to the novel ROIO design. So let's start with stepped wedge and a little bit of history about when this came about and why, and then where we're at now. So this was actually the stepped wedge itself was coined by the Gambia Hepatitis Study Group in 1987. So the study design has been around for a long time. In this particular study, they had 17 sites that were rolled out in 5 different clusters over a 4-year period. And this was more or less the diagram that they used to show what the stepped wedge looks like back in the day. You'll see some much more contemporary pictures of this, but at the same time, nothing really has changed for the basic and fundamental aspects of stepped wedge. They're more or less the same as they were in 1987. So how did Brown and Lilford, when they published this initial paper in DMC Medical Research Methodology, actually define what a stepped wedge is? So they said there are 2 conditions, a control condition and a new intervention. And you can think new implementation strategy here for implementation studies, but either way, it's a control period followed by an exposure to an experimental condition. Your total time period for the study is going to be divided into sections following a series of steps. So we'll show that in the next slide. Each unit, whether it's an individual or a group, is assigned either randomly or not. Most commonly, it's random. To a time period that they will begin receiving the intervention. So essentially, their position in the rollout sequence is the randomization. What that actually means, and this is sort of the subtext, is that everyone who is in the trial eventually gets exposure to the experimental intervention, which is one of the benefits of this type of study design. One of the requirements, though, is that in a stepped wedge, you have to measure all units at all time periods to be truly a stepped wedge. So we'll look at that here in a second. So what do I mean by steps? So steps in a stepped wedge design, this is a 11 step, 11 time period clinic level example, but doesn't really matter. Those parts are kind of erroneous here. The point is that essentially from the left hand side, which is our control, the crossover points essentially get pictorially displayed as steps. So that's what the steps is, or steps are in a stepped wedge design. The wedges are the other piece. So everything below on the left-hand side of the steps is your control data or the control wedge. Everything above after crossover to the experimental condition becomes your intervention wedge. And so the combination of these two sources of data allows you to do your comparison. One of the reasons that people do like stepped wedge designs is that because you are actually leveraging within site change, which basically means the comparison of this control data to intervention multiple or replicated or aggregated across time, you increase the amount of power that you have to detect an effect over a traditional parallel cluster randomized trial design. So that's one benefit of these is that they are often a bit more powerful, but there's some other drawbacks that obviously we'll talk about that need to be considered.
Mm.
So that's your standard stepped wedge. Okay, so what does randomization look like in this? I've kind of already mentioned this. We tend to randomly assign to the starting sequence or to the position in the sequence. So meaning they don't know when they will necessarily cross over. They just know they'll be the third in line. And then you tell them right before the crossover that they're now entering into the intervention condition. If timing to sequence is not randomly assigned, similar to any other randomized trial design, it introduces potential sources of bias. And so it can erode trust and scientific rigor can be compromised for these study designs. So the other part about this type of design is, as I mentioned before, when you are recruiting for a stepped wedge, you are telling all of your potential sites, your potential participants that you will eventually get the intervention. You just don't know when because that's part of our randomization and our rigorous trial design. But because of this, everyone anticipates that they're going to benefit in some way, right? Eventually. So we need a fair way to assign these different units to the timing. And so we do random assignment, of course, to try to minimize expectation effects and other sources of bias and confounding. These are not, these studies don't have great equipoise, but you do have a little bit of a similar benefit for your position in the sequence. So there is a benefit of going early or being assigned early in the sequence. You're going to benefit from the intervention or the strategy earlier or more immediately versus going later. You have to wait. And so you're not benefiting, temporarily to the same extent. But the implementation or the effectiveness of the intervention may actually be improved or sort of go better through experience or learning, whether or not that's an explicit goal or attempt to improve over time, like you'll see in the ROIO, or whether that's just through, kind of a typical learning effect that might happen. Okay, so some advantages of stepped wedge designs and rollouts a bit more generally. I will say this is definitely from a researcher perspective, asking community partners and implementation partners their perspective on the benefits and drawbacks might be a little bit different. But here are some of the things from a researcher's perspective. So concerning ethical issues, you are in a stepped wedge or rollout asking some communities to wait. So you are essentially withholding treatment. This is not anything different than you would in a typical parallel cluster randomized design. But in this case, you are going to be withholding something that they expect to happen. And so it's a slightly different ethical issue. We should obviously be concerned about this too. And there are situations that withholding effective treatments or trying to address urgent public health needs with implementation strategies that then take multiple years to start may be an unethical consideration. So that the ROIO design and the stepped wedge or rollout, generally speaking, does not solve the issue of that. It just may mean that different trial design is needed altogether if there's these complex ethical issues. So one aspect that's an improvement over alternative designs, and usually when I say alternative designs, I mean more just parallel group randomized trial designs. This trial design can help avoid the readiness bias of non-randomization if you're randomizing to their position in the sequence. And it helps us to actually isolate the test of the effect of the intervention rather than are we just testing people's readiness to start, right? So randomization within these is really helpful for that. In contrast to some in the field who have said that stepped wedges are not true experiments, um, we would very much disagree with that. These are true experiments when you do have rigorous trial design methodology, when there is randomization, when there's good balance, and you actually can have really strong causal inference from this design, even with a modest number of sites, because of those advantages you get from the within and between site comparison of a typical stepped wedge. Okay, so let's get into rollout designs. So we're switching gears a little bit here. I wanted to kind of level set with what a stepped wedge is, because I'm sure everybody has at least heard of that, probably seen them, maybe thought deeply about them, or been involved in a project that used them. But stepped wedge is one very specific type of rollout design. The rollout design umbrella, the big class of study designs of rollouts, is much broader. And unfortunately, I think most researchers think of stepped wedges almost every time you think of a rollout design. And it's kind of just the tip of the iceberg in many ways. So there are lots of different steps beyond the stepped wedge. Obviously, this is an MC Escher to show this point. So what are the defining features of a rollout design? But many of these are similar to a stepped wedge, but are not quite as restrictive, as you'll see. So units are assigned to when they are exposed to the different implementation strategy condition. These can be randomized or non-randomized, but again, reducing bias through randomization. All rollout designs have one or more crossovers. So that's one thing that's quite different from a stepped wedge. A stepped wedge only has one crossover, meaning you have one intervention. And that is a defining feature. Anybody who tells you otherwise, it's wrong. So if you have a situation where you're trying to test two different things against one another in a rollout context, you cannot do so in a stepped wedge. It violates one of the assumptions and key characteristics. In most cases, I put this caveat in here because there is a couple of examples that I'll show you where there is a control condition within a rollout, which is, again, something that you cannot do with a stepped wedge, but you can do with this broader class. All sites will eventually get exposed to the strategy if you're in the active strategy condition. Okay. So what are some of the pros and cons of rollout designs? So some of the pros is that these are often very appealing to community partners because they all know they'll eventually get support to implement their evidence-based intervention. Nobody is going to be randomly assigned to a true control condition where they provide data for 2 years, 3 years, 4 years, but never actually get the benefit. There may be a waitlist control condition for those control sites, but still, it's a lot to ask sites to wait for years and years to potentially get implementation support. These are often very practical designs for resource allocation and to minimize burden on systems. So you can imagine a large scale rollout design, if you have, let's say, dozens of sites, maybe even 100 sites, the ability to actually deploy implementation support simultaneously, as you would need to do in a parallel cluster randomized design, is very difficult, right? And so having teams that can sequentially roll out can be really good for resource allocation. There is an ethical, sort of benefit to this that all units eventually get to implement. You may also need fewer units than a traditional RCT as you're combining the within and between site comparison. So that is a pro for us, both reducing costs and just the pure challenge of engaging multiple implementation sites. There is a little bit of benefit for going earlier and later, which starts to get into an equity consideration. That's not always true, but that can be the case in certain ways. So some of the cons, Most rollout designs take longer because of these, obviously the rollout nature of these studies. They will take a longer study period to gather the data necessary to answer your question compared to a parallel cluster randomized design. So that is one negative of this is you sometimes do need an extra year, if not longer. You do have the delayed start for some units, which may or may not be acceptable to your implementation and community partners. In most, and again, this is that caveat that there are examples that there is control. But in situations where you don't have a control unit, it limits your evaluation or ability to evaluate long-term effects, sustainment, and to estimate underlying secular trends that can affect, obviously, our interpretation and causal inference of the findings. They do have a risk of bias due to misspecification of causal or of secular trends that we don't have time to really talk too much about. But if anyone has a question, maybe we can get that in the questions at the end. Power assumptions can be particularly challenging for all types of rollout designs, but it's generally better than parallel because of degrees of freedom and some other considerations. But just knowing that we often, unfortunately, I think, underpower rollout designs because of assumptions we make about IPCs. But that's, again, a talk of it for a different day. It gets pretty technical. So rollout design, generally speaking, if you're talking about just design elements of a rollout design, your selection of units to randomize are typically going to be clusters in implementation science. You could do individual level step wedge or rollout designs in implementation, but that's probably much less common than doing clinical teams, clinicians, clinic locations, health systems, counties, other types of units, because that's typically the unit of analysis or the unit of the implementation strategy that we're trying to apply. So that's most commonly what you're going to do for your selection. If you have homogeny, it really does help because of balancing across the clusters in the rollout design. But heterogeneity can be handled with randomization, assuming larger samples, where doing randomization-based inference and other, covariate adjusted randomization, stratification, blocking, all those sort of things that we typically do in other places. Having a large enough sample of sites, you can handle quite heterogeneous, site characteristics. But balance is a very important piece of any cluster randomized design. So again, your allocation is really to sequence. It's not to intervention or not. It's to when you're going to start the intervention. Your assessment or measurement of your outcomes. So you measure the outcome for a period before the crossover, of course, to the active implementation. And then you measure long enough after the crossover to feel confident that you've been able to detect the effect. So that will really depend on the nature of the question that you're trying to ask, whether there's a delay in being able to detect an effect versus a more immediate evidence of an effect. But again, there are exceptions to having a pre-evaluation. I'll show a couple of examples where there is no actual true baseline. So basically, that whole control wedge is irrelevant. But again, that's a sort of a unique sequence or situation. So we have a paper that is it may not have actually been submitted yet, but it will be submitted in the next day or two if it's not actually already under review. It's a paper titled "What Scientific Inferences Can Be Made with Implementation Rollout Trials." And so I pulled some examples from this paper that was led by Hendrix Brown, and then I was second author. So here's an example of a rollout design that it looks a little bit like a stepped wedge, but what this design actually has is it adds in a question of sustainment. So in a typical stepped wedge, there is no sustainment period. And part of the reason that there is no sustainment period is that you have to satisfy that full wedge data requirement. And in this, you have basically a second crossover point. Okay, so you have crossover from your baseline to the implementation of a new intervention or implementation of a new strategy. And then you have a sustainment period. The sustainment period assumes that either a different supports have been started for sustainment, okay, which is very common to have, more sustainment strategies that begin after a year of implementation, let's say, or you could actually just reduce or take away implementation supports to see if there is a sustained effect even after withdrawal of of implementation support. So any question that folks have about measuring sustainment within a rollout design, this RO1 that's led by Willie Prado at University of Miami and Hendricks Brown as MPIs is a great example of this in action. And we have analysis plans and some other really helpful information about how to actually go about doing these in the paper. So another study design that you can do with a rollout is what we call a head-to-head rollout design. So a head-to-head rollout design is where you actually have two different implementation strategy conditions, and you're going to evaluate these head-to-head, one against the other, in a rollout sequence. So in this case, you have two different randomizations. You have randomization to sequence. Are you going to be in cohort 1 through cohort 7, or and you are also randomly assigned to which implementation strategy you get within the cohort that you're in. So this allows us to actually test two different strategies or two different interventions. This is very similar to a comparative effectiveness design, but it's testing strategies. So Hendricks and I typically refer to these as comparative implementation design, just to differentiate a little bit from comparative effectiveness research, which focuses obviously on the intervention effect and trying to maximize effectiveness. There's also a very similar related one, which is a head-to-head rollout that uses the fractional factorial. So this is where you can actually have more than two components that are being tested. This is the most simple fractional factorial, where you have component G, component H, and then component G plus H as your three different conditions. And so again, you randomly assign to the sequence and randomly assign to which of the component conditions. But because we have sufficient number of units here, you see that the number of cohorts increase compared to the prior example. The more complex you get with the number of conditions, typically the more clusters you'll need for power and balance considerations. But just to say that there are ways to do this type of fractional factorial with more than two conditions. So kind of a fun example. I don't know if there's actually a funded example of this, but either way, we simulated data to be able to create the power analysis and some of that stuff that's available. Another example that is a funded project by Peter Wyman that Hendricks Brown is involved in. This is a study that they really felt like they needed to have a external control. So again, in a typical stepped wedge, everybody eventually gets exposed. In this study, these are actually Air Force bases. So the clusters are Air Force bases, and this is a suicide prevention program. And you have very similar to the prior example that was looking at sustainment, you have control periods crossover into the active implementation of the suicide prevention program, and then a withdrawal of implementation support to examine whether or not the effects that were achieved during implementation can be sustained over time. The fifth base that was involved, or at least contributed data, served as a control. So the control group is not, you can see the reason that it's actually in like more of a bold blue. It is not really the same as the control condition here, because it's not going to be included in the analysis in the same way. So the reason that this external control was used was really to be able to estimate effect against no intervention, of course. That's one piece that you could incorporate as a secondary analysis. But the other reason was this allows for a very good estimation of underlying secular trends that you cannot get in these other bases because they've all had exposure. So we've actually changed the trend, but we don't know if we've changed it consistent with or if it's been confounded with an underlying secular trend that's due to other forces external, obviously, to the research project itself. Situations where this is actually feasible and acceptable to do is when you can get the same data through like an administrative data system and the site actually is not involved. So that's the interesting thing about this base is they did obviously give permission to use their data, but they're otherwise not doing anything differently. They're not getting trained. They're not collecting additional data. It is existing data that is already collected that is the same as the data that's already collected at these bases to be allowed to do this. You could potentially pay a control site or enroll a control site for this purpose, but it's best suited for when you have access to existing data sources that would be comparable to what you're using in your project. It's a pretty cool design here. A very similar type design is what we have called an adjunctive three-phase sequential rollout design. And this allows us to examine whether during the sustainment period, improvements in implementation outcomes have been maintained over baseline. This is very similar to two previous examples, one of which was the sustainment question. So you see we have the sustainment period. We also have the external control, which basically serves as our comparison to the sustainment period versus no intervention. So this just allows you to ask and answer a couple of different research questions or additional research questions than you would without having that external control. So you can kind of see that we tried to build essentially different features and elements in this paper, showing the flexibility, but also the range of implementation research questions that you can address. One question that we have, I'll get to this in the ROIO, because there's one more piece of this paper that gets into essentially more quality improvement or improvement over time that is either unintended or intentional. So we'll talk about that here in a second with ROIO. Before we get into ROIO, I just want to put a little bit of a plug for two papers that are really useful for implementation researchers and thinking about designing rollout studies and their analysis. So one is by Avi Kenny and colleagues, and I'll actually give some details about that here in a second, that has to do with time varying treatment effects. And then the other one is a paper that I co-authored that is a very detailed statistical analysis plan for a stepped wedge cluster randomized implementation trial called the New Impact Trial that was funded by the National Cancer Institute. This is a situation that we published a full protocol paper that had an analysis plan in it. And then we realized that the analysis was way more complicated. And we went back to the journal and said, would you entertain an updated statistical analysis plan as a standalone publication? And they did. So it's a really good paper for folks wanting to get more information about how to evaluate implementation outcomes within a stepped wedge, which that's the only reason they got published. Is this was a fairly novel situation. So take a look at that. So in the Kenny paper, the analysis of time varying treatment effects. So in in step wedge studies and in almost all rollout designs, there is an assumption, at least analytically, that there's what is called essentially an instantaneous effect, meaning that as soon as the crossover occurs, the exposure to the intervention happens, you will see an effect that starts immediately, right? So that's what's called an instantaneous treatment effect. This is the default for basically any analysis plan that you're going to use or analytic approach that you might use for a stepped wedge. What happens though, and you can probably, if you're, done any implementation research, you probably understand that most of our implementation strategies do not have the same instantaneous effect as some interventions might have. And so we're often actually violating the assumption of an instantaneous treatment effect to our detriment. And I'll show on the next slide why that's the case. But essentially, this paper talks about three different alternative time varying effect models, or what's called an estimand. The technical term not necessary, but you essentially can have a lagged effect where you don't have an instantaneous. It takes a little bit for the strategy to start working. Then you start to see the effect, and it becomes sustained. You also have a curved effect where the effect itself begins almost immediately, but it takes quite a while for it to actually get to sort of its maximum effect. And so you can model this underlying curved effect. And then you also have a very similar, what's called a partially convex model, which just shows varying rates essentially of effect over time. And so if you essentially assume, or if you don't incorporate these underlying time varying treatment effects into your analysis and just use the default, what ends up happening is, of course, if you have an instantaneous effect, it looks great, right? The estimated and true effect are the same, and you probably have some very significant findings. Maybe submit your paper to JAMA, feather in your cap. If not, and you have a lagged effect, the true underlying data structure is a lagged effect, but your actually, analyzing it under the assumption of an instantaneous effect, you will have a null finding, right? Because this underlying assumed pattern does not match the true data. Similarly, for a curved effect and a partially convex and a curved effect, you do have some instant effect, but it's not very strong. And so the actual modeled effect is going to be very different than the true effect. And this is probably a non-significant finding as well. Then you can see in the partially convex model, that's the same as well. So this is my little soapbox to say that if you're doing an implementation rollout study, whether it's a stepped wedge or some other rollout design, very carefully consider if you want to specify an a priori non-instantaneous treatment effect. We did these as post hoc effects, essentially as a secondary analysis for our study because we did not pre-specify this for our cluster randomized stepped wedge that's part of that Schulten's paper. So you'll see a little bit more information about that, but it was a much better fit to the data when we had a curved treatment effect. Okay. Um, so what are some issues too with traditional rollout designs? This is kind of getting us thinking about the ROIO. So in most traditional designs, all units get the same exposure. The implementation strategy is exactly the same. That is an underlying assumption that you typically have to get met to do the analysis models for a stepped wedge. Um, but in reality, especially in implementation and pragmatic studies, is that really the case? Is that true, right? Do we actually adapt the strategy sometimes over time because we realize it's not working that well? Do we actually have a learning or a sequence effect, meaning we get better at implementing the strategy, therefore the effects are better over time. And so we end up having a sequence effect, meaning those who are later in the sequence actually get better more quickly or actually just achieve higher results. If things get better over time, like if you do see a sequence effect in your analysis plan, is that a problem? Is it a good thing? If you're a statistician who's tried to do this, you will probably say it's a problem because the sequence effects, when they are unintended, do statistically cause a lot of, not a lot, but they cause several issues that have to be dealt with, and they're typically not a good thing for a traditional stepped wedge design. So what do you do if the implementation strategies are ineffective in early clusters? Do you just adapt? What do you change? Can you change it? In a very true a priori clinical trial framework, you probably shouldn't change, right? You're actually violating several assumptions that are going to make your analysis much more difficult, and the ability to draw conclusions will be harder as well. So, typically you would not change, especially not drastically, implementation strategies. But that also is something that would be a disservice to our community to say, oh, we realize this is not working, but we have to do it anyway for the next 4 years. That would really not be a good thing. Oh yeah, that would be a waste essentially. So the ROIO design is sort of a product of trying to address some of these issues with the traditional assumptions of a rollout design, as well as integrating a bit more of a quality improvement perspective into a rigorous implementation research design. So what ROIO designs do are test iterative improvements in implementation over time. But these are different from just testing for a learning effect. So a learning or a sequence effect can be done with any rollout design. And it's really just saying, is there any treatment by sequence effect that's happening? And usually you don't know why. You can assume that it's because of learning effects or other things, but it's not intentional. The ROIO is intentional. You are actually trying to improve over time by doing certain things. So what is the goal? The goal of a ROIO is to improve implementation with each successive cluster or cohort in your rollout design to identify the optimal strategy. I will define what optimal means here in a second. So the optimization feature of a ROIO design is planful and prospective, and it uses early quantitative and qualitative data to inform adaptation or tailoring of strategies for subsequent units in the rollout. Okay, so essentially this means you get multiple bites at the apple to figure out an optimal implementation strategy. So some of the methodological challenges in designing a ROIO, one is actual initial strategy selection. What are you going to start with? And what are going to be your parameters or essentially your options for optimization and adaptation as you move through your rollout sequence? Um, I'll say more about this a little bit, but more or less, this means that you need to have a really well-defined multi-component implementation strategy upfront with options for how you may adapt it if certain strategies look like they're either suboptimal or simply infeasible or ineffective. How many clusters and steps? It kind of depends. Do you need two, three, four attempts at improvement? You'll see in some of my examples, we have three clusters. So you have two attempts to improve. A couple others, we had four, meaning you have an extra attempt to improve. But part of this actually is how good do you think your initial implementation strategy is going to be? And you might want an extra shot if you feel like we just don't really know at all how this is going to go. And so you might want one more shot to improve. What about your rollout schedule? So you want to ensure sufficient time between clusters for optimization. This is really different than a stepped wedge, where you could actually have clusters in your stepped wedge start every month. And that's very short time period, but that still works. In a ROIO, you're typically 4 to 9 month step between cluster starts, and that's because of this need for uh, mixed methods analysis. Um, in Arroyo 2, your selection of outcome metrics, you really need to pick things that are very sensitive to change, and also have some high meaningfulness, right, for the clinical challenge. So we often do incorporate some criterion-based evaluation within Arroyo, but either way, your metrics have to be sensitive to change to be able to do this. You also have to have measurement and evaluation that's rapid and informative of needed changes. And we'll talk a little bit more about that. And then finally, having a process for how you actually decide about what is modified, moving from cluster to cluster, and ensuring that this is protocolized, that it's replicable, and that the process is transparent, right? So the worst thing we would want to have is a situation where someone says, well, why did you optimize or why did you adapt the way that you did? And your only answer is, well, it sounded like it would be good. It's just not something that could be replicated and not something that likely is going to actually be rigorous, scientifically driven. Those are some of the challenges that just to keep in mind as we go through what this looks like. So here's an example that I hope will give a little context to what this might look like. This is published in the Proctor, Colditz, and Brownson DNI book in 2023. So if you'd like more information, it's in the chapter that Jeff Curran led on design and analysis of implementation trials. So the context for this is that there's a pretty well-known underdiagnosis of pediatric hypertension or elevated blood pressure. The population prevalence is only about 4%, so it's not a very common disorder, but it's less than 30. When you look at multiple studies, it's about 30% of kids who actually have the diagnosis ever get diagnosed in primary care. And if you don't get diagnosed, there's no treatment. There aren't usually no treatment plans associated, of course. And so it's a problem. The clinical practice guideline for pediatric hypertension was released in 2017, and it is highly complex. It is a very difficult practice guideline to implement, and so that was our focus here, was to actually help people to become more adherent to the hypertension guidelines, which have been shown to lead to better identification of kids who actually have hypertension or elevated blood pressure. So our primary aim for the study was to optimize a multi-component implementation strategy package to improve identification of children with hypertension or pre-hypertension in safety net health centers. Our measures that we are going to be using to inform optimization, then again, this is not the primary outcome measure. We'll talk about that in a second, but the measures for optimization are going to be mixed methods. So our quantitative measures are largely going to come from the electronic health record. This would be evidence that they are following the pediatric hypertension guidelines. So that's evidenced by repeat BP measurements being done, diagnostic rates increasing. And then we will also be using rapid qualitative analysis to analyze transcripts of staff focus groups, interviews with BP champions at the implementing sites, as well as interviews with pediatricians and physicians. And so you'll see that obviously there's multiple sources of input and multiple groups that essentially inform the optimization procedure. So what does it actually look like? So this is the example design that we included in the book chapter. This is one that has 24 clinics organized into 4 clusters. On the left-hand side, of the diagram here in this kind of turquoisey color or teal or whatever this is your pre-implementation data. Okay, so this is your control data essentially. You could have control data that is a full wedge. There's no right or wrong way to do this. In this study, we had it a little closer to the crossover point to minimize measurement burden, but you could include data from earlier in the rollout sequence as well. The part that is really the ROIO, though, starts at the crossover. So this is implementation all the way across. But essentially, this first 2 quarters are where you'll be getting the early data to help inform how you're going to optimize as you move to the next cluster. So these little red arrows are essentially showing this data contributes to the protocol here. And then data from both clusters contributes to cluster 3 optimization decisions. And data from all 3 clusters would help inform the adaptation and the implementation strategy package that would be deployed in cluster 4. So you can probably already see what this is leading to sort of analytically or conceptually, but we'll get to that in 1 second. What I wanted to start with first is strategy optimization and strategy selection. So we published a paper in Implementation Science Communications in 2022 that actually lays out a replicable, generalizable method for strategy selection that is particularly well suited for an optimization study design, but we have used it in situations where it wasn't an optimization design. It was just a community driven and partner engaged methodology for strategy selection. But for this example, we identified a package comprised of multiple discrete strategies. So this is basically multiple bundles that then comprised the package of multi-component strategies. We identified those with our community partners, and they were involved in helping us prioritize them. The prioritization process was really a rating of how feasible this is for your organization and your clinic to do, and how likely do you think it's going to actually be effective in overcoming the barrier that we associated it with and the outcome that we're trying to achieve. And we use the implementation research logic model as well as an adapted ERIC kind of Delphi process for strategy selection that was incredibly helpful. The IRLM itself is a really useful tool for this approach because it really helps you conceptually think about why you're using the strategies. And then, of course, in optimization, if strategies are not working, it's really helpful in helping diagnose that problem and figure out what other strategies might be able to be introduced or amplified to enact the mechanisms that you think are needed to be changed to achieve the outcome. So what can you do in optimization? So once you have the initial strategy package, you test it, you get initial data, quantitative and qualitative, to see how things are going. What are your choices for trying to make this strategy package better as you move into cluster 2? You can obviously add more strategies. Okay. I'm not a fan of the kitchen sink approach. I don't think that adding is always the default option, but that is obviously something that you can do. So adding in a strategy that maybe is less feasible, but is likely to be highly effective, might be a good option. Of course, we're looking for removal of ineffective or infeasible strategies. So if a strategy is being used that just really is not working, you may just want to take that out. That might mean replacing it with a different strategy, or it might just mean it comes out. You can also change the intensity of the dose or frequency of strategies in the package. So something that may be showing some effects, but maybe not as much of an effect as we had anticipated or assumed it would do, we might bump up essentially the dose and frequency to try to increase the effect of that. Okay, so let's look at some analysis questions. So our primary outcome here was the rate of accurate diagnosis. This allowed us to have cross-sectional data every month that could be modeled as a trajectory that you see in the bottom right here. So we have multiple analysis options that are all sort of complementary, right? They answer different questions, but together they help us determine what is optimal. Okay. So in this particular study, we modeled a time to criterion type expectation. where we thought that, at least for the initial clinic, the first cluster of clinics that we were working with, we think our strategy is going to work, but it's not going to be optimal yet. And so we modeled a time to criterion of 18 months to get to a 25% increase in the diagnostic rate. The later clusters, we thought as an average of cluster 2, 3, and 4, we would be able to achieve that 25% criterion here within about 5 months. And if that's the case, we would expect that our maximum effect that we might find is about 20% higher than our initial clinic. So the way to test this is a non-parametric test. This is I can't remember if we were going to use we were using a Kruskal Wallis. It's in the next slide or in the next click here. So essentially, you could test whether or not you were able to improve on the first cluster, right? That's the only question that this really tells you is, did we get better from our first cluster? But then we also want to know, as a complementary analysis, which is analysis B here, is there improvement over time between clusters where we can actually look at these four clusters independently and see which ones differ from each other? And so to do that, it's a multi-level trajectory analysis. You can see that we did have power, at least for this particular study, based on these assumptions, to be able to do it. The multi-level trajectory of analysis is obviously much more powerful because you are looking at differences in slopes and have much more data contributing to it than the non-parametric test that is comparing just two different clusters. Okay. The other piece that's really important for determining the optimal or best strategy package is what's called an incremental cost effectiveness ratio. So in contrast to comparative effectiveness research, which is mostly just trying to figure out which is the most effective intervention, which one can achieve the highest effect size, we also care about cost here. So incremental cost effectiveness ratios essentially are what is the cost, additional costs or difference in cost between two different clusters actually representing a cost effectiveness in achieving a particular implementation outcome. And in our case, it was the cost of the implementation per 100 children. And of course, we still have the same outcome, which is the percentage improvement in diagnosis. And so what this will help us do is really say between those four different options in our cluster randomized ROIO, which one is the most cost effective as well as the highest effect size. And so the combination and triangulation of this data will go into determining which one is the most optimal strategy. I don't have much time left to get into this, but I will kind of at least tease it. We have a newly funded P50 from NIMH that is using a ROIO design, but it is using a ROIO split plot, meaning we actually have kind of similar to those prior rollout examples that I had where there's multiple exposures. In this one, we actually have one project that is going to start, go through the ROIO process, so 2 attempts to get better, and then after a period of time, additional implementation strategies that are a priori are going to be added. And what this allows us to do is test some of those main effects and interaction effects to see if the strategies we use in the initial project are enhanced or work synergistically with additional strategies that are meant to address specific implementation barriers that we've already identified with our community partners. So pretty cool that we're going to be able to do this. And it actually has 2 different implementation strategies at different levels that are being implemented or introduced later in the study. So pretty cool design, I think. And you'll see more about this in the future as this project unrolls. I also want to draw some attention to a funded R01 that is on COVID-19 rapid evaluation and testing, where Nicole Stadnick, Borshika, and colleagues at UCSD applied a ROIO design, but with 4 clinics. So instead of clusters of clinics, which have been all the types of study designs that I've done, this particular study actually only had access to 4 clinics, and it's a slightly smaller R01. And so they're trying to optimize clinic to clinic. But similar strategy, similar design as the rest of them, maybe not quite as powerful just given the number of sites, but still a reasonable design for this small N that's here. That's the end.